Next chapter is contact lenses. Contact lenses are the most commonly worn as an alternative to spectacles by those who perceive the wearing of spectacles to be unattractive or inconvenient. Contact lenses are safer than spectacles for many sports and occupations because they do not fall up, break, fog up, become spattered in rain, or impair the use of protective eyewear. Contact lenses are optically superior to spectacles. In some cases, they reduce or eliminate the aberrations associated with spectacles used to correct high refractive errors. They also reduce anisoconia associated with anisometropia and high degrees of astigmatism. Contact lenses are used diagnostically and during surgery to view the fundus and trabecular meshwork. A number of non-refracting contact lenses are used in ophthalmology, like bandage contact lenses, which are precorneal membranes. They are used therapeutically for ocular surface disorders to protect and promote healing, to relieve pain. A painted contact lens may be worn to improve the appearance of a small or an unsightly blind eye and to provide an artificial iris and iridium. A type of contact lens with an attached electrode is used to perform electroretinography. As you can see in these pictures, ERG jet contact lens electrode. You can also see in these pictures ERG jet electrode for an iridia, first artificial iris, FDA approved. Now the geometry of contact lens. Now the refracting power of the optical zone, which is the central zone of contact lens. This is the optical zone. The refracting power of this optical zone of a contact lens is determined by its anterior and posterior curvature, the thickness of the contact lens, the refractive index of the contact lens. Torsion of a contact lens may be prevented by incorporating 2 diopter base down prism to the weight of the lower pole of the lens. 2 diopter base down prism. Another way to prevent torsion is by truncation, removing the lower 0.5 to 1 mm of the lens to allow it to sit on the edge of the lower eyelid. Now what is the base curve? It is the base curve of contact lens is the posterior central curvature. This is base curve. The shape of posterior surface curvature of a contact lens should conform closely to the aspheric surface of the cornea to ensure a correct fit. Now what are tricurve and bicurve lenses? So the aspheric shape may be created by encircling this optical zone with 1 or 2 concentric zones of increasing radius of curvature to produce a bicurve or tricurve contact lens. Now the junctions between these zones are made smooth by a process called blending. And the base curve and the diameter of the contact lens determine how tightly the lens fits the cornea and how easily it moves with each blink. Corneal contact lenses have a smaller diameter than the cornea. As you can see in this picture, corneal contact lenses have a smaller diameter than that of the cornea. Scleral haptic contact lenses have a peripheral rim which is supported by the sclera. They are large, 25 mm diameter. Contact lenses made of gas impermeable materials. One is gas permeable and one is gas impermeable. So the gas impermeable may therefore incorporate fenestrations to facilitate the circulation of tears behind the lens. because the corneal surface is oxygenated by tear film. Contact lenses which are used to correct high refractive errors have greater thickness and they have greater weight. So there will be problems. A high power concave lens has a thick edge. So a high power concave lens, a minus lens, has a thick edge. Tendency of the upper eyelid to grip the thick upper edge of the high power concave lens and cause it to ride high is countered by a peripheral. So a high power concave lens has a thick edge, and the tendency of the upper eyelid to grip the thick upper edge of a high power concave lens and cause it to ride high is countered by a peripheral bevel. The weight of a high power convex lens that causes it to drop to a lower position can be countered by a minus peripheral carrier portion which tends to be lifted by the upper lid. Tear lens and astigmatism. The tear film between the posterior surface of contact lens and the anterior surface of the cornea is known as tear lens. If a tear lens has uniform thickness, it has plano power. A contact lens of steep base curve it is known as plus tear lens. A contact lens of flat base curve is known as minus tear lens. So this is plus tear lens because the base curve is steep. This is minus tear lens, the base curve is flat. Power needed for contact lens: refractive error minus tear lens power. So this must be subtracted, tear lens power. This tear lens allows a special spherical contact lens to neutralize corneal astigmatism, and the base curve of contact lens should be the same as the corneal surface curvature in the flat meridian. So the same as the flattest meridian of the cornea, where the cornea is steeper. Then the tear lens is thicker and neutralizes the astigmatism. So it is convenient to express the prescription using negative cylindrical powers because only the spherical component need to be prescribed. Soft contact lenses neutralize no more than one diopter. Soft contact lenses are only for one diopter, while rigid lenses can normally correct larger degrees of corneal astigmatism. Astigmatism arising from the crystalline lens or an implanted intraocular lens from the crystalline lens or implanted intraocular lens will only be neutralized by a front surface toric contact lens. Difference between contact lens and spectacles. Contact lenses reduce aberrations associated with spectacles. When pupil is dilated, a rigid contact lens may cause a halo effect because of refraction through the peripheral zone of the lens or adjacent tear film. So this is plus lens, image magnification, decrease field of view, while minus lens, image magnification and increase field of view. Hypermetropic spectacle lenses, there will be image magnification and decrease field of view. Myopic spectacle lens, there will be image magnification and increase field of view. Changing from spectacles to contact lens produce in hypermetropic patients, there will be image magnification and increase field of view. In myopic patient, there will be image magnification and decrease field of view and improved visual acuity. Anisoconia is reduced with contact lenses compared with spectacles. No prismatic effect occurs with contact lenses which remain centered. Myopic spectacles has a base in prismatic effect which reduces the amount of convergence and accommodation required for near. So a change to contact lenses needs greater convergence and accommodation, which may cause eye strain in presbyopic myopes. It is possible to incorporate up to 3 diopter of prism power into a corneal contact lens without making it too thick to be practical, but the weight of the prism rotates the contact lens so that the prism is always base down. This makes horizontal prismatic correction impossible and limits the prism to one lens only. Carefully fitted squirrel lenses allows incorporation of a vertical or horizontal prism up to 6 prism diopters divided between the two lenses. Contact lenses may incorporate a slight blue tint to make them more visible. For easier handling and retrieval, contact lenses may have a deeper green, blue, brown tint, sparing the center to make the iris appear a different color. Bifocal contact lenses, the accommodation in presbyopic, pseudopachic, apachic patient is reduced or absent for near tasks, so they need spectacles or contact lenses, or bifocal contact lenses, or monovision. What is monovision? Monovision, there is fitting one eye, usually the one with better vision, with a distance contact lens, the fellow eye with a lens which corrects near vision. So, patient must learn to adapt to having to concentrate on the clear image from one eye. Binocularity and stereopsis are diminished. Various bifocals and multifocal contact lens designs are available. Annular, aspheric, segmental, diffractive. Annular bifocal contact lens. They have a central zone. This is the annular contact lens. Central zone for distance, surrounded by annular zone for near. So in down gaze, the contact lens rises relative to the cornea, placing the near portion in front of the visual axis. Light from distant subject that passes through the portion of the lens which focuses for distance produce a clear retinal image. However, under these circumstances, the light passing through the near portion of the contact lens produces superimposed out of focus image. The blurred image reduces the quality of the clear one. The reverse applies when viewing a near object. The viewer learns to concentrate on the better focused image. A major drawback of the annular bifocal is that the peripheral annular portion of the lens is not as effective when the pupil diameter is small. Aspheric multifocal contact lens, the central part of the lens corrects for distance, and there is a gradual transition in power to the peripheral portion which corrects for near. Segmental bifocal contact lens, they incorporate the near addition over the lower portion of the lens. The eyes look through the distance portion in the primary position, and down gaze the contact lens rises relative to the cornea, placing the near portion in front of the visual axis. Segmental bifocals must be prevented from rotating by truncation or by ballasting with the base down prism. Diffractive bifocal contact lenses, they have concentric diffraction rings on their posterior surface which are designed to focus equal amount of light from distance and near objects. Near and distant correction is put in each ring. The image is less bright than with a single focus contact lens, and this may be a problem in dim illumination. Keratoconus, the increased corneal surface curvature in keratoconus, myopia and irregular astigmatism frequently progress. Mild cases are amenable to spectacle correction. Moderate cases are amenable to correction by rigid contact lenses. Historically, haptic contact lenses were used, but newer corneal lenses are designed to sit on the cone. In severe keratoconus, when the cone is too steep or scarred, corneal grafting may be necessary. Optical problems associated with contact lens wearers. Short-term problems. If the posterior surface of contact lens is too flat, it will move excessively on the cornea and the edge of the lens may cross the visual axis and cause the vision to fluctuate with each blink. Movement of the upper eyelid during blinking over a soft contact lens press against the cornea can cause temporary fluctuation in the visual acuity. The coated power of the soft contact lens denotes its power when it is suspended in saline at room temperature. Small changes occur when the lens is in use. The lens molds to the surface curvature of the cornea. The evaporation of water increases the refractive index. An increase in temperature increases curvature. The latter two factors increase the negative power of the lens. Increased temperature and the evaporation of water. A dry atmosphere on an aircraft cabin may cause blurred vision during and after flight because of the increased evaporation of water from soft contact lens cause negative power. Long-term problems. Corneal warpage is the change in corneal curvature induced by wearing a contact lens which is not associated with corneal edema. It regresses after the lens is removed over hours or days. During this time, any spectacle which were once accurate no longer compensate for the altered shape of the cornea and spectacle blur results. Warpage is more pronounced and of longer duration when more rigid lenses are worn. It is important not to perform refractive surgery or biometry to estimate intraocular lens power or to prescribe spectacles before these changes have stabilized.